Good afternoon, everybody, and thank you all for joining us for a very important conversation on understanding maternal mental health and stigma. My name is Paige Bellenbaum, and I am a licensed clinical social worker and a perinatal mental health specialist, and it is a true honor to be the moderator of this exceptional panel discussion. Before we get started with today's event, we'd like to share a message from the New York State Office of Mental Health Commissioner, Dr. Ann Sullivan.
Hi, I'm Dr. Ann Sullivan, your Commissioner for the New York State Office of Mental Health, and it's my pleasure today to welcome you to the roundtable discussion on maternal mental health and reducing stigma. We're working today in partnership with Mental Health News Education to bring you this roundtable discussion. We're very excited that you're all joining us here today because the issue of maternal mental health is so serious. We all know that 1 in 5 women during the prenatal and postnatal period have significant anxiety and mood disorders. We also know that a large number do not receive the treatment that they need. So how do we make a difference? The first thing we need to do is put best practices into our healthcare system. Practices such as screening women for depression and anxiety disorders before their baby is born, and then for at least up to a year or two afterwards, because we know that postpartum depression can come 6 months to a year or even longer after the birth of the baby. We also need to pay a lot of attention to stigma, because one of the biggest issues is still that women are not comfortable with admitting that perhaps they are anxious or depressed during pregnancy or after their baby is born. We need families to understand that this is a real condition that can be treated and that can make a big difference in the lives of the women and the babies that they are caring for. So maternal mental health is clearly a major priority. We know the terrible statistics that show that mortality during pregnancy is higher for Black women than for white women, actually 5 times higher. That means that as we design our services, we have to be sure that we are there to work for every community, and especially those communities at higher risk for maternal depression and maternal morbidity. We have done a lot of work to increase the ability for our professionals throughout our system to get the help they need in working with moms who may be depressed. Something called Project Teach that we put in place to have specialists available for anyone working with a pregnant mom or with a mom after the baby is born, to be able to call and get assistance if they have any questions at all about what might be helpful for the women they are working with. So Project Teach, please call if you need to. We also have a trauma-informed network that can help with tons of resources for practitioners across the system to know how to work with moms in need. So please use our resources, but also tell us what else we need to do. That's what the roundtable discussion is all about. So again, thank you for coming today, and I know that the ideas and concerns and suggestions that you're bringing forward will help us all to serve better our moms and our youth.
Hello, everyone. My name is Karen Wagner. I work within the Office of Quality Improvement for the Office of Mental Health. I'm a licensed psychologist as well, and I lead the OMH strategic plan for mental health stigma reduction. Dave, would you want to bring up those slides? I just want to review a couple of important points regarding continuing education credits, which we'll be offering 2.5 CEUs for social work and psychology. We will be recording this roundtable. We'll be providing that recording and the presentation slides with all of the attendees. You'll be able to view and download after the session. Type all of your questions into the Q&A as you think of them. We'll be compiling them for the Q&A at the end of the session. And as you know, the chat is open for interacting, saying hello, and networking. But please don't use this for your questions. For those applying for CEUs, a survey will be emailed to you after the event. So please complete that by November 20th before the second roundtable. You can expect those certificates within 1 to 2 months after the event. Any questions, just email me at that email address. And then Dave, the next slide. These are the statements. OMH is recognized to provide education credits for psychology. We're an approved provider for psychology and for social work. Those are our approval numbers and CEU statements. And I don't want to take up any more time. I do want to mention we have that second roundtable. This is the two-part roundtable discussion series on maternal mental health and mental health stigma. And the second roundtable is next week on the 20th, and that is the registration link. So without further ado, I give it off to Paige again to continue the discussion. Thanks so much. Thanks everyone for being here.
Thank you, Karen. New and expecting mothers and birthing people across New York State are suffering. 1 in 5 pregnant and postpartum people experience a perinatal mental health condition, including depression and/or anxiety, and 75% of women and perinatal people impacted by these conditions remain untreated, increasing the risk of long-term negative impacts on mothers, babies, and families. Perinatal mental health conditions are the #1 complication associated with childbirth and the leading cause of maternal mortality in this country. In fact, the latest New York State maternal mortality report found that mental health conditions were a consistently leading cause of pregnancy-related deaths each year from 2018 to 2021, and that 100% of pregnancy-related deaths due to mental health conditions were determined to be preventable. In response to these startling statistics, just last week, Governor Hochul announced New York State's first ever report on maternal mental health, led by the New York State Office of Mental Health and drafted by the Maternal Mental Health Work Group. This landmark report provides a detailed pathway to improve the mental health of pregnant and postpartum women and birthing people statewide. In conjunction with the report, today's event is the first of a 2-part maternal mental health stigma reduction roundtable discussion series. As Karen mentioned previously, we encourage audience members to register for part 2 of next Thursday's events, if you haven't already, titled Maternal Mental Health Support Programs and Solutions to Overcome Stigma. It is now my great honor to introduce to you our esteemed panelists, Dr. Christina Deligianides, Director of Women's Behavioral Health at Zucker Hillside Hospital, Northwell Health, and Medical Director of Reproductive Psychiatry at Project Teach, New York. Kriti Lodha, Marketing Executive and Advisor and a member of the Board of Directors of Postpartum Support International. Dr. Britton Mahaffey, Assistant Professor of Psychiatry and Behavioral Health, Women's Mental Health Integration Lead and Dialectical Behavior Therapy Program Director at Stony Brook Medicine. Dr. Lauren Osborne, Associate Professor of Obstetrics and Gynecology, Associate Professor of Psychiatry and Vice Chair for Clinical Research in Obstetrics and Gynecology at Weill Cornell, and Dr. Ashonda St. John, Associate Professor of Obstetrics and Gynecology at New York Medical College and co-chair of the New York City Department of Health and Mental Hygiene, Maternal Mortality and Morbidity Review Committee. Before we launch into the questions for today, I'd like to invite everyone in the audience to participate in a quick poll that's going to give us a sense of who all is joining us today. If you can just take a moment to respond, what is your professional primary role? And we're going to share the results with you towards the end of today's conversation and ask you to take just one more poll at the very end. And Dr. Deligianides, I'd like to start with you. As a leading reproductive psychiatrist and researcher in the perinatal mental health community, can you begin our conversation today by describing the perinatal mental health conditions seen in pregnant and postpartum people and the prevalence of these conditions?
Yes, thank you so much for the opportunity to be part of this important roundtable discussion. So we'll start with perinatal depression. Thank you for putting that slide because it'll summarize a little bit about what I'm going to overview now. But we'll start with perinatal depression. This is clinical depression that can occur during pregnancy or typically within the first year postpartum, but it can be even later. And if untreated, it can last up to 3 years without treatment. Common symptoms can include persistent sadness, loss of interest, fatigue, sleep and appetite changes, feelings of worthlessness or hopelessness, and also difficulty bonding with their infant or other children. Can affect anywhere between 10 to 20% of birthing persons. And this might manifest as a new mother experiencing pervasive sadness, struggling to care for her infant, and then withdrawing from her family, maybe reluctant to seek help due to stigma worsening her symptoms. Perinatal anxiety disorders are a group of distinct but interrelated conditions. And those are characterized by excessive fear and elevated emotional response to perceived threats. The symptoms you can see in patients would be excessive worries about the baby, irritability, racing thoughts, and physical symptoms such as heart racing or sweating. Prevalence is high, 7 to 20%, and many studies do cite 1 in 5 perinatal individuals. It's frequently undiagnosed and often occurs with other mental health disorders. Perinatal obsessive compulsive disorder involves symptoms including time-consuming and functionally impairing, intrusive, unwanted thoughts, images, or urges, and we call these obsessions. They can involve fear of harm coming to the baby or fears around baby safety, and they can be violent in nature. Patients have described a fear of a baby drowning when they're giving them a bath or that they're stopping breathing overnight. And then the second core symptom are repetitive behaviors or mental acts performed to reduce that anxiety from those obsessions. And these are called compulsions. So the patient is compelled to repeatedly check on that baby or clean the baby bottles or remove dangerous items from the home, seeking reassurance that everything's okay. Prevalence here is estimated to be about 8% in pregnancy and 17% after delivery. Lifetime prevalence rates are lower, so it's thought to be an increased vulnerability in this time frame. And this might manifest as a postpartum parent repeatedly checking if their infant is breathing. So using apps and devices that monitor breathing, the patient's unable to sleep will stay awake to make sure that baby doesn't stop breathing in the middle of the night. And they'll often hide their symptoms because of shame and stigma. Perinatal bipolar disorder can be present prior to the peripartum period, so prior to pregnancy or after delivery, and can relapse during that period, or it can be a new onset of the symptoms. Main symptoms can include episodes of mania or hypomania, and what this means is what we see as elevated mood, rapid speech, impulsivity, poor judgment, alternating with severe depression. What's important about bipolar disorder is that the lifetime suicide risk is 15 times the general population. Prevalence is 1 to 2% in perinatal individuals, but there's an increased risk during pregnancy and postpartum, especially for patients with a history of bipolar disorder. Here we may see a postpartum patient cycling between periods of extreme energy and sleeplessness, followed by episodes of deep depression, making self-care and infant care very difficult and a significant risk for the development of postpartum psychosis. So postpartum psychosis, psychosis can occur in pregnancy as well, but postpartum onset psychosis is an acute, severe disorder, usually occurring within days or a few weeks after delivery. Symptoms here are quite different than what we see in perinatal depression or anxiety. They include hallucinations, delusions, disorganized speech, rapid mood swings, and confusion. This is an emergency. It's a medical and psychiatric emergency requiring immediate intervention and evaluation due to the risk to the patient and the infant. Prevalence here is 1 to 2 in 1,000 births, and the risk increases for those with a history of bipolar disorder. It's really thought to be a part of that disorder. And so what are those hallucinations? Hallucinations when your brain acts like it's getting input from your senses, either your ears or your eyes, but without any actual input. So the things that you see and hear feel real, and the patient's unable to tell the difference between a hallucination and something that's truly happening. Patients may hear voices commanding them to act in ways that can hurt themselves or their baby and children. And then delusions are false beliefs, beliefs that you hold very strongly to. Examples include persecutory delusions, believing someone is after you, control delusions, feeling that someone else is trying to control your body, or bodily delusions. Some patients may insist that they did not have a baby or weren't even pregnant. And then finally, post-traumatic stress disorder occurring in the perinatal period. PTSD can result from trauma experienced before, during, or after birth. Symptoms can include flashbacks, nightmares, hypervigilance, avoidance of reminders. There's a higher prevalence in those experiencing traumatic birth or those experiencing intimate partner violence or other trauma in pregnancy, with a prevalence rate of about 3 to 6%, but likely underdiagnosed. Here, a patient may have experienced a life-threatening postpartum complication or hemorrhage. She may experience nightmares, avoiding hospitals, feeling detached from her baby, struggling in silence due to the fear of being seen as ungrateful. So this sort of encapsulates some of the main perinatal mental health disorders that we see and gives just a brief overview of how they may present in peripartum individuals.
Dr. Delagiannis, thank you so much for that extensive overview of what these conditions look like and what the prevalence rates look like. Before I move on to the next question, I just wanted a follow-up question for you. I think sometimes there can be this perception that these conditions might manifest in the immediate postpartum. It's probably new to a lot of people in our audience that these conditions can transpire during pregnancy, right? In fact, 50% of all cases can originate in pregnancy, the other 50% in postpartum. Is it true that we see the majority of these conditions immediately postpartum, or is it possible for these conditions to develop later on in the postpartum period?
Yeah, it's a great question, and one that I think our language gets complicated because even just the language we use, postpartum depression, really that's kind of misleading, right? Because then it discounts the 50% of perinatal individuals that actually have the onset of impairing depression during the pregnancy. And I don't know how many patients we've seen or individuals we've spoken with where they say, oh, this can't be PPD because I'm pregnant, or I didn't have anything like that in pregnancy because you can only get that after giving birth, right? And so it's really important for us to educate that these conditions can occur in pregnancy or after delivery. And that's why, I said psychosis can occur in pregnancy as well. So sometimes the language gets in our way. There are many mental health disorders that can occur further out in the postpartum period, just due to the all of the different stressors and psychological and psychosocial things that are happening in a patient's life that may be more removed from those hormone changes of the pregnancy postpartum period. So yes, that's why I think many of our organizations have really moved to encourage screening for a much longitudinal, longer period of time, rather than just, oh, a quick check after delivery, right? So you see the professional organizations really moving to screening in pregnancy, in the early postpartum, and then beyond.
Thank you for that. I now have a question for Dr. Mahaffey. As someone who's studied the intersection of stigma and mental health extensively, what role does mental health stigma play in the context of maternal mental health conditions?
Thank you so much, Paige, for having me here, and I'm so glad that OMH is doing this. It's such an important topic. When we think about stigma, plays a huge role in preventing people from getting access to care, across the lifespan and across different types of mental health conditions. But I think it's particularly important in the perinatal period because we have all these beliefs, right, that pregnancy is meant to be the happiest time in your life, when in reality, we know that over 50% of pregnancies in the United States are unintended. And even those that are, planned and intended may be accompanied by a lot of psychosocial stressors that make it much more difficult for women to be well and to have mental health during their pregnancy. And one thing I like to point out is that the common saying is mental health is physical health. Well, I really want to point out here that maternal mental health is child health. And I think that's something that we really need to keep in mind. So when we think about stigma and mental health in general, and specifically stigma related to mental health in pregnancy, we're really trying to think about a couple of different types of stigma. One is public stigma. So public stigma is these kind of cultural values and beliefs that we hold that are being kind of embodied through sort of our general beliefs about whether mental health is acceptable and whether accessing care is acceptable. So these stereotypes and prejudices that we all hold. And I think one of the key pieces here is that in general, in our culture, we tend to view the child as the priority above and beyond the woman and the woman's mental health. And again, as I said, maternal mental health is child health and mental health. So we really need to break that association and really prioritize women's well-being for both for themselves and for the well-being of the child. Self-stigma is then how we internalize these sort of public beliefs that we all hold, these cultural norms and values. And so when a woman experiences, or I'm saying woman here, but any childbearing person experiences a mental health problem, if we've internalized this belief that this should be the happiest time in my life and I'm anxious or I'm depressed, what does that mean? Why am I not happy? What's wrong with me? And that can really lead to a lot of shame. And that shame can then in turn prevent people from seeking access to care and talking about it with both peers and, which can be an important source of support, and mental health providers. And then we have this layer of structural stigma. So this includes things like our policies. Do family members receive time off for taking care of their own mental health, both during pregnancy as well as during the postpartum? People are going to a lot of doctor's visits. Time becomes incredibly precious when you're a pregnant person, and having time to care for both your physical health and mental health can be extremely challenging if you do not have time off, paid time off from work, which is a huge structural factor at play. In general, policies around things like access to abortion, access to other services, access to other care is something that is happening at a structural level. Do we have access to affordable health care? These are all factors that can increase and contribute to structural stigma as well that may be less obvious. So when we're looking at addressing these things, we really want to be prioritizing raising awareness and encouraging people to talk about mental health problems that they're experiencing, to talk about these mixed feelings that can arise about being a pregnant person, to seek care from providers. We really want to be educated ourselves about these conditions. A condition I'm particularly passionate about is peripartum onset OCD. This is a huge one where, especially if people are experiencing intrusive thoughts about harm coming to the baby and perhaps even doing harm to the baby themselves, that they're anxious about. What if I shake my baby? What if I dropped my baby? What if I hurt my baby in some way? Those types of thoughts can be incredibly shame-inducing for people and can prevent people from getting access to care. So as mental health providers, for those of you here who are, as well as physical health providers, I really hope we have some obstetricians and PCPs here. We need to know what peripartum onset OCD looks like so we can normalize that experience and kind of bust that shame so that people can get help. And then we really just need to make sure that we have access to care available. We know that when people are screened for mental health conditions like depression and we don't actually follow up with them or provide connections to care, that can actually lead to worsening mental health problems. And so, because again, it implies that your mental health is not important enough for me to follow up when you're telling me that you have difficulty. So we need to also make sure, and this interacts with that structural stigma, that we have referral systems in place and that we have access to high quality care in place that we can provide to people. And so the last point I'm going to make here is please, 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 if you are a person who is childbearing, if you are somebody with mental health problems yourself, if you are a provider, if we see stigma out there, if we see prejudicial language, discriminatory language, please speak out, right? Advocate about it, talk to your patients, normalize the experiences they're going through, talk to your friends, share about your own experiences if you're somebody going through this. We know that support that you offer and receive is both important for your mental health and that of others.
Thank you so much for that, Dr. Mahaffey. It really frames the conversation around the roles that stigma plays that we're going to get into throughout today's dialogue. And I just want to say, to piggyback on what you shared, is that we can never make assumptions about how a new mother or birthing person or pregnant person is doing. We cannot judge a book by its cover. That because of this shame and stigma that so often people feel when they're not having that blissful, beautiful experience, oftentimes can feel compelled to go to great lengths to hide it, to cover it. And so we have to be comfortable asking the questions, because just by looking at someone doesn't tell us the full story of what's actually going on. I'd now like to ask our other panelists to offer their additional insights on both perinatal mental health conditions and prevalence, as well as the roles that you see stigma playing in these conditions. So I want to open it up.
Well, I'll jump in. One of the things I think we use these words shame and stigma, but I think we did not add the word of fear. Because we know often part of the stigma is also the weaponization and the penalization of actually either being diagnosed or even admitting that they're not the perfect mother, right? And that we kind of strive towards perfection. And so we have a lot of social media platforms where everyone looks like they're doing it great, but inside they may be suffering. So I think there are several different levels of fear that one may have. And so how do we kind of normalize those discussions, right? Because I think as clinicians, we've often been the trusted messenger, right? But there's also a lot of misinformation, disinformation, and platforms where a lot of our patients go to before they come to talk to us. So using those validated screening tools, screening often, screening frequently, developing a bridge of trust. These are all strategies that, number one, help destigmatize mental health conditions, but also open up the platform and the floor for our patients to, number one, talk to us, right? And really kind of also tell us it may not be going great, right? And that's okay. We are so used to and normalized in this country, how you doing? Fine, right? Sometimes people are not fine. And so how do we really kind of develop those bridges and fortify that trust so that they will talk to us? And how do we integrate mental health into our normal practices? One of the things that I have always tried to do is we know that prenatal and postpartum visits are a really consistent point of healthcare for pregnant women and pregnant individuals, right? So how do we infuse mental health screening into that so that we can kind of have an integrated approach? And so those are kind of the things that I think about.
Thank you, Dr. St. John. Dr. Osborne?
Yeah, I'll just piggyback on those remarks. I agree with everything the other panelists have said, and I think that stigma among people who are experiencing the mental health disorders, among their families, among their friends, among the public is really, really important. I also think, unfortunately, that we're combating stigma among healthcare providers. I think even if healthcare providers don't want to or don't think they're engaging in stigma, I think about mental health in general. There's an enormous stigma and people don't think of it as the same. I'm a psychiatrist, but I work in an OBGYN department. And one of the conversations I often have with my colleagues is, well, you have a patient with gestational diabetes and you're treating that as a complication of pregnancy. If you have somebody who has perinatal depression, that's also a complication of pregnancy. The brain is part of the body, just as all the endocrine organs are, and we really have to treat it the same. And I think that that's a really hard thing to get across to clinicians. And I feel like those of us who work in this space, we're ambassadors for that among other healthcare providers. And I think it's our job to treat them, to bring them along and to give them non-judgmental, dispassionate information about what these disorders are and how related they are to pregnancy. I think a lot of people who are clinicians who deal with physical health don't think of these conditions as actually connected to pregnancy and postpartum, but they of course very much are. And I think a lot of people are really open to being educated about that. They're not trying to engage in stigma, but that's just the way our culture and society has brought them up, and it's our job to bring them into the fold.
Thank you for that, Dr. Osborne. And I want to move to you next, Kriti. And I just want to say, yes, we have hundreds of people here today doing exactly that. So a shout out to everyone who is taking the initiative to learn more about these conditions. Kriti?
So first of all, it's an honor to be in the company of these amazing clinicians. As not a clinician, I am the case study in stigma, everyone. I'm proud to say I am a postpartum psychosis survivor. I am a South Asian woman. The fact that I'm speaking in front of hundreds of people when I suffered in silence for 3 years, this many people knew what I went through. So stigma and shame is real. So I literally feel goosebumps from everything I heard. I was like, provider stigma, check. Seeking help stigma, check. So everything you all are saying is so important. So I just wanted to start with that. I mentioned I suffered in silence for a few years, and it's a medical emergency, as we talked about earlier, perinatal psychosis. The one thing I want to kind of emphasize also, now that I work in this space, is really the stigma and the recovery process as well. And so how do we remind patients that they're more than their diagnosis? The reality is, let's say best case scenario, you get access to help and treatment, and you have incredible providers like the ones on this call, and all of you. At the end of the day, my brain failed me, my body failed me, potentially I failed my partner, my baby. In some cases, there might be other structural, as we talked about earlier, structural stigmas or even consequences, right? I'm a privileged woman. Not everyone is as privileged as I to have gotten the care I got without consequences to me and my family. And so the other thing I'd say is, like, there's so much stigma in the recovery process as well. And so best case scenario, let's say we get the right diagnosis at the right time with the right providers. Please don't stop there. Whether that's grief and loss of, maybe I didn't make the feeding choices that I needed to, or what we talked about earlier, like the identity changes of the mom I wanted to be, or frankly, what does it mean in my workplace? What does my circle of disclosure look like, for whom and with whom? And that's assuming that you're not dealing with like provider bias and all the things that you talked about earlier, Dr. Osborne. So I just think that, like, I think the other thing I'd say about stigma is that it's a long road. And unfortunately, even despite the best privilege in providers, shame and stigma and self-loathing can go a long way. And I think what's really beautiful, it's weird to say beautiful, about this illness is that it's exquisitely treatable. If you all saw where I was at a few years ago to where I'm at now, night and day. And so let's help patients and families get out of their own way by reminding them that they're more than their own diagnosis or comorbidities, and giving them space to sort of heal and grieve everything that they carry that goes along with that, even if they get help, I think is really important as well. So know that recovery journey is also a long road for many folks, regardless of what perinatal mental health complication they had. And so how do we make sure we're supporting them and the family unit in that as well? And I don't want anyone to have to suffer in silence for 3 years like I did. And so how do we really make sure that we're getting to the root cause of that as well, would be the one thing I'd add.
Thank you, Kriti, for sharing that with all of us and for being such a profound, open, powerful person in this space by using your story as a tool for change. And I think that you hit on something that's so critical that we need to keep front and center, is that all of these conditions are treatable. We know what to do. We have interventions that work, that fall on a continuum of care, and that is hopeful. And that's what's going to make the change, is the more we know, the more we can connect those that are struggling to the hope and the care and the support that they need and deserve. I'd like to pose a question to all of you. Each of you come to maternal mental health from a different perspective, including research, treatment, policy, lived experience. And I invite all of you to talk about how you are working towards improving perinatal mental health outcomes.
I'm happy to jump in first, but first, I just really want to applaud Kriti and just thank you for sharing your story. I think when we kind of normalize these conversations and we are able to be open and we are going to help so many people. And so I am so thankful for you to share that. And, I think that when we kind of go along the framework of perinatal mood and anxiety disorders, we have to also recognize 50% of women and birthing people are untreated, right? And so that's where the shame, stigma, and fear comes in. And so one of the things that I have been intentional about is not only integrating mental health screening, right, throughout the prenatal and postpartum visits, right? Because again, we know that's a consistent point of healthcare, but also using the validated screening tools, normalizing the discussions, normalizing the importance of emotional well-being, and how do we really kind of infuse the joy back? Imagine someone going through pregnancy and not enjoying anything about the pregnancy because there's fame, there's fear, there's stigma, there is anxiety, there is depression. We often talk about postpartum depression, but you can be depressed during the pregnancy, right? And it can start before the child is born. And so this is why it's important to have those screening tools and having that mental health screening, but also recognizing what we learned during COVID is the elevation of the virtual platform and utilizing telehealth and flexible scheduling to really kind of address and remove common barriers of transportation, of childcare, of time constraints. One of my goals has always been to ensure mental health is not siloed away from obstetrical care, but understand that it's central to maternal health care. So how do we do that, right? And so one of the things I have done in my practice and amongst the people that I work with in my department is having a practice that's rooted in trauma-informed care, harm reduction, and also anti-racist care, because we have to really infuse respect, right? And when we try to think about trust, we have to also understand empathy and compassion and lived experience and shared decision making. We understand that, we know that Black women and Black birthing people are disproportionately impacted by maternal mortality, but we also know that maternal mental health conditions are the leading cause of maternal mortality throughout the country, right? And so when we normalize this space and we develop those bridges of trust, we will get more, will be more in a position to help others. And we have to recognize that substance use disorder or even mental health conditions are medical conditions. Like my colleague said, if it was diabetes, we would treat it, right? We'd give the insulin. So why are we thinking otherwise? And sometimes we have to really make sure that our patients understand that it's not a failure, right? These are not personal failures. And so we have to be intentional about creating spaces where there's safe discussions about depression, about trauma. There's no fear of punitive action. And how do we really elevate birth equity and ensure dignity? Right? And also cultural responsive care. One of the things I love that Kriti talked about is her ethnicity and her culture and her background. These are very stigmatizing as well. So you can't even admit it to your own family members, right? And so we often sometimes wear this cape of that we are these strong, women or mothers, right? When we're just dying inside, right? And we just want that help. So, one of the things that I think of is working collaboratively with our pediatric partners, because after they deliver, right after that postpartum period, they're still seeing their pediatrician and they're doing screening evaluations as well. And how do we kind of really kind of attach, in the framework of a medical maternal home model, right? How do we all work together to the betterment for our patients? So these are kind of the things that I kind of do and instill. Also making sure that my providers are able to prescribe medication-assisted treatment, and also understanding the importance of peer support, social services, lactation counseling, and then also postpartum planning, right? We understand and that maternal mortality actually occurs in the late postpartum period. So that's after the 6 weeks, right? And this is one of the reasons why we have extended in New York, Medicaid coverage for the whole entire year, because we understand it doesn't stop at 6 weeks. And so how are we intentional? Well, we can be, right? When we want to really put a patient-centered framework and elevate our patients to really serve them and provide for the needs that they have.
Thank you, Dr. St. John. Go ahead, Dr. Mahaffey.
So thank you. I think those are such incredibly important points. I think what I'm doing in our practice to try to address some of this is really looking at prevention and access to care. I have had medical providers come to me and literally say, why would I talk to a woman about her mental health if I don't have a place to send them for care? That is a huge problem, and it's going to continue to lead to us not talking about it if we do not have resources to provide. And so I'm really pleased that New York State has an initiative to support rolling out collaborative care in OBGYN practices. Collaborative care is this embedded care model where we can really quickly provide access to medications, to brief psychotherapy right there within your OBGYN office. And nothing says it's okay to talk about your mental health care, and your mental health care needs, like having a live person there that you can be handed off to, right? So we need to be supporting those kinds of initiatives. And I think it's fantastic that New York State is doing that. We also need to be remembering that the best predictor of postpartum mental health problems is actually the person's mental health history, even before pregnancy. Why are we waiting to have these conversations until after the baby is here? Why are we waiting? We don't have time. We need to get in there early and often, and we need to be also assessing maternal stress, and especially things like pregnancy-specific stress, which is worry about the pregnancy, parenting, and childbirth, and getting in there and treating that. We can treat that. We don't have to wait till somebody is depressed. We can equip people with behavioral skills, with cognitive skills that can help them to think more flexibly, that can help them to build a social support network, to be better problem solvers. And we know that those things are protective. We actually know maternal optimism is protective. And how can you be optimistic if you don't have access to resources? So we need to be talking to people even before they get pregnant about their mental health. So if you have somebody that's coming in for fertility planning, we need to be having these conversations even at that point. And that's where I'm really passionate about, is that prevention and getting away from this excessive focus on postpartum depression. I think it's also stigmatizing to be a person with an anxiety disorder in the period of pregnancy, because we don't talk about that as being a problem, and we know that more people are affected by that, and that untreated anxiety can also lead to depression. So I think we need to be focusing on prevention, integration of care, and brief evidence-based care, and making that accessible to everyone.
Thank you, Dr. Mahaffey.
I can jump in next. And I think, I agree with everything that's been said so far. And all of those are incredibly important points. When I was thinking about how to answer this question, because Paige, you gave me a hint ahead of time that I would have to answer this question, I thought about what is it, particularly I was thinking about what makes my point of view distinct from that of the other panelists. And I think it's really that I am coming from a place where I have many different hats within the maternal mental health world. And if I try to figure out how do all of those hats fit together, it's that I'm really passionate about trying to improve care on a population level. So my primary hat is that I'm a researcher. I do research on biomarkers and biological mechanisms of perinatal mood and anxiety disorders. And I do that because I really want to get at some of the answers, and I want to understand what is the cause of these disorders so that we can develop new treatments that are either better than or more acceptable to women than the ones that we have. And so that's trying to improve things in the aggregate for a whole population. But then in addition, my clinical world is I run a collaborative care program within the Weill Cornell New York Presbyterian sphere. And we at the moment are covering about 15,000 deliveries a year in 3 of our 4 hospitals. We have one that we're not quite there yet. And that, again, is population level. We screen every person who comes in for prenatal care at 3 time points, and we give them all some form of care. Now, do they all get twice a week intensive psychotherapy and careful medication monitoring? No, but that's not what everybody needs. And we try to meet each person's needs where they are. And again, that's improving health on a population level. And then the other hats that I have are I'm deeply involved in education. And so I run a project called the National Curriculum in Reproductive Psychiatry. And the purpose of that is to educate the workforce, because we don't have enough people who know how to treat these disorders. And one of the things I like to say about the point of collaborative care is that you don't need somebody with my level of training in maternal mental health to treat mild to moderate depression or anxiety. You just don't. And so we save the people with the higher level of training for those more complex cases. And that's the same thing with workforce development. If we educate everybody on how to recognize and treat mild to moderate cases, then we are making it possible for the really complex cases to be treated by the specialists. And then I would say the final pillar is that I'm very involved in kind of policy and advocacy. I'm working with a group to try to create board certification in reproductive psychiatry. And I'm involved in, been for many years on the board of Marseille of North America, which is the major perinatal mental health research society. And again, in that platform, it's to try to get out the word on a population aggregate level to what we need to do. And before I started to think about this question, I think the things I do are so different and how do they cohere together? But it's really that focus on the aggregate and on the whole population that I think I bring to this.
Thank you, Dr. Osborne. Before we give the other two an opportunity to respond, my mind is thinking of like, you cover the micro to macro, everything from population health all the way down to individual treatment. And because we've brought up the collaborative care several times, if you don't mind just giving a quick overview of what that means so that our audience members understand.
Absolutely. So I'm very passionate about collaborative care. So collaborative care, and it took me a while to bring my colleagues into the fold with the concept that it really is collaborative. It's a model of care that started out, the original evidence was in primary care medicine, where there would be a team taking care of the patient, the primary care physician, a behavioral care manager who's often a social worker, but could be a nurse or could be another licensed clinician, and then a psychiatrist who serves as a consultant. And they work together in a team. The behavioral care manager is the sort of eyes and ears of the team, is going to administer brief psychotherapy, help to get the patient to additional resources that he or she needs. And the psychiatrist is doing a quick overview of all the cases and making recommendations that then the primary care physician carries out. So we're doing this in obstetrics now. It's less common in obstetrics, but there's a growing movement to do it in obstetrics. And there are differences between obstetricians and primary care doctors, and so working out those kinks. But essentially what it means is partnering with our obstetric colleagues so that if I have somebody with mild to moderate illness who can be treated with therapy alone or with therapy and one relatively simple medication to handle something like an SSRI, the obstetrician will prescribe the medications with guidance from me to say, this is how you dose it, this is how you titrate it. And then that care manager is the person who's meeting frequently with the patient, monitoring symptoms, and then coming back. Another key cornerstone of collaborative care is that there's a registry. So it's population level health. We're tracking symptoms across time and keeping track of who's getting better and who isn't, so that we know who do we need to step up to the next level of care. And so as I said, it's a model that I'm very passionate about, and New York State is kind of at the forefront in encouraging this model. It's in a bunch of other states as well, and a bunch of places that don't have state support, but it's a model that, in conjunction with access programs like this sort of stuff that Project Teach offers, I think we're providing sort of a full suite of support for our obstetric colleagues in order to bring them into the fold and follow those ACOG guidelines that say, yes, mild depression and anxiety are within the scope of treatment of an obstetrician.
Whole health. Dr. Delagianitis, I saw you wanted to chime in.
Yeah, it'd be fun too. So similar to Dr. Osborne, I also wear related hats, and it's sometimes, it's like, how does all this fit together? Because sometimes you're doing very different things, even within an hour, right, of our day. But I also lead a research team looking at sort of the biology. Why is it that women are at higher risk of developing psychiatric illness across their lifespan, right? What is it? Everyone says, oh, it's the hormones. Yes, and why? And what are all the other things that contribute to? And how do they all work together to increasing risk for an individual across, from menses to menopause. And so I do biological work there as well. But then I also, as Director of Women's Behavioral Health at Zucker Hillside, I oversee all of our clinical programs, from our ambulatory specialized program to our intensive program to our inpatient women's unit as well, and try to look at, all of those services that we can provide on the psychiatry side, but then also our collaborative care and increasing behavioral health access to peripartum individuals and women's behavioral health more broadly. Echoing on the population health theme, and I wanted to speak actually more about Project Teach. So what is Project Teach? And so as medical director, this program is New York State's Child, Adolescent, and Perinatal Psychiatry Access Program. It's funded by the Office of Mental Health. And what we do as a team is we address major barriers to care. So that includes lack of provider expertise and pervasive stigma, while strengthening and expanding the clinical and community response to maternal mental health. So one way we improve outcomes is by expanding the frontline provider capacity. So more of us need to understand about perinatal mood and anxiety disorders and perinatal mental health disorders to be able to address this within non-psychiatric, non-mental health settings. So Project Teach offers real-time phone consultations to a wide range of providers, not only to OBGYNs, but also pediatricians, primary care clinicians, midwives, doulas, therapists, nurses, home visiting staff. This gives frontline professionals immediate access to those specialists, right, that are somewhat few in the state, and mental health experts for assessment, treatment planning, and medication safety during pregnancy and breastfeeding and beyond in the postpartum period. Project Teach also provides no-cost in-person and virtual training, as well as scholarships for perinatal mental health certification, including the National Curriculum for Reproductive Psychiatry, and also for Postpartum Support International. So what we want to do is build provider confidence and competence, ensuring more accurate diagnosis and responsive care to individuals. And the education goes beyond diagnosis and treatment. While the cornerstones of what we need to do and to educate our community, we also need to equip providers to recognize their own biases and to be able to communicate without judgment, and to adopt trauma-informed, culturally responsive approaches. So these competencies are important for countering the structural stigma that deters help seeking. We continue to see how stigma infiltrates the use of antidepressants in pregnancy conversation. And you're right, there's prescribers who are afraid to treat peripartum individuals because of lack of education. They never got that training in their clinical program. So we want to right that wrong and give everybody the education that they need so that they feel confident to do the work that so many of them want to do, but feel inhibited. Our program's phone consultations and educational resources also invite providers to see perinatal mental health as that core universal aspect of maternal care. By normalizing those conversations about mental health along physical health, the stigma that these concerns are rare or shameful or unmanageable is reduced. I think that normalization is really important for reducing both the public and self-stigma. And when discussions of mood, anxiety, and trauma and substance use become as common as your blood pressure check or your fetal heart check, then stigma is reduced and the patients feel safe, to speak up. Because how many patients have come to us? I see that, they were screened in their obstetrics practice or midwifery practice, and I saw that their score on their scale was like 0, right? And so they're like, "Oh, you're doing great," And then, 2 weeks later, they're in our center, and I administered the same screen, and it's off the charts, right? And I'm like, what happened? It's like 0, and oh, I couldn't talk to her about that, or I couldn't talk to that doctor about that. I had to wait to come to see you. That we have to get rid of that, right? And so then another gap that was cited in the New York State morbidity and mortality report was that referral and treatment gaps, right? So we might be screening, but then we can't get the patient to the specialized care they need. And so our team at Project Teach will help and assist providers getting their patients access to therapy, support groups, other community resources to help these families navigate a somewhat very complex, not somewhat, a very complex system and reducing those delays. So Project Teach as New York State's perinatal psychiatry access program really sees stigma as a multi-level barrier. And we intentionally target to empower a wide range of providers to normalize discussions at every, whether it's the WIC counselor, it's a case provider, if it's midwifery, it's lactation consultant. We want everyone to be empowered with the education to really support the standard of care that perinatal individuals need, so that it's a statewide culture in which seeking help for these issues is an expectation and not an exception.
Thank you, Dr. Delagianides. And before we hear from Kriti, I just want to say we are lucky in New York to have a psychiatric access program. Not every state has one. And what a tremendous resource as our audience is hearing. We do have resources here in the state, and how important it is to take advantage of them, because this is exactly what they're aiming to do, is to offer that support and guidance. Kriti.
Yes, I'm smiling because like 2 years ago, I was in hospitality technology and I used to run the Mr. Clean brand. So I was in a very different world than a lot of folks on this call. Honestly, I had the same reaction as Dr. Osborne, where I was like, I now wear a lot of hats. So how do I like organize it? Really, it's simple. I feel like postpartum psychosis happened to my family for a reason. And that reason is I happen to have the professional skill set in my career. I think the potentially sometimes fearlessness at this point. I would have been in Gryffindor for any Harry Potter fans, to just say I'm going to tackle the maternal mental health crisis head on. So if you ask me, I don't know what that's going to look like in 6 months, but like that's my mission. I want to tackle it. Everything is exquisitely treatable. Moms and birthing people are dying. Families are suffering. This is a systems problem that can be solved. We know exactly what problem we have to solve and how to solve it. We just need to take a systems approach to solve it. So that's sort of like where I'll start. So I was sort of like, just like Dr. Osborne, what's the kind of thread? So I kind of have it by themes. I think first and foremost, I hate to use a cliche, but in anything advocacy, I wear an advocacy hat. Representation matters. So to me, I'm looking at all the folks on this call. I know some folks on this call might be moms, birthing people, non-birthing partners, frontline caregivers, community advocates, whatever role you take. If one of you feels seen or heard by anything I've said, or frankly, you don't like it, ignore it. Like that's a big part of my mission, is just how do I do that? I did not have that. I wish I did. And so for me, I think representation matters. And I would say the whole family unit as well. So I think the fact that Paige, I'm so honored that you and this group has lived experience at the table. Bring lived expertise and experience at the table. We've lived it. And so the way that I might look at the same systems problem as someone else on this call, or all of us have different backgrounds, as you've heard, that's the power. The power is in the collective. So I think that's really important. And honestly, for every story of fear or dire outcome, and trust me, in the postpartum psychosis world, there's a lot of those. There are so many more stories of hope and resilience and recovery. And so I think it's also important to change the narrative collectively as well. I think on the other end, and I love that you plugged Postpartum Support International. I'm on the board of that organization as well. Community matters too. So Postpartum Support International, not only on the state level, the national level, or the global level, is one of the largest nonprofits that's really empowering families, partners, non-birthing partners, providers around resources around your recovery journey, whether you're pregnant, postpartum, post-loss, trying to conceive, really all aspects of the journey to becoming a parent. And I think, I'm so proud that even in the most trying of times, we have free virtual support groups for not just diagnostic factors, but psychosocial factors. So you can go to a group, actually facilitate groups for psychosis survivors is one of my hats. So you can go to that group. You can go to the Moms and Multiples groups, the South Asian moms, the trying to conceive after, termination for medical reasons. I mean, eating disorder groups, there's so many. So the groups are constantly evolving. So please, if you get time, go to postpartum.net. There are over 50 free virtual support groups, peer support programs, peer mentorship programs. And then on the provider side, you've been hearing a lot about building the workforce. And I love what's happening with the NCRP, but even on the kind of perinatal mental health provider side with PSI, how do we actually equip people to get certifications? And I know Paige plays a big role in this as well, to actually be equipped to take care of this. So to me, I was shocked now that I'm in this role that like, wait, just because you're a therapist and a psychiatrist, just because all of a sudden I'm pregnant, you don't have the medical training to actually help me. Like that's absurd, right? And so to me, perinatal mental health is on the same journey that pediatrics was on. Like there's no reason we shouldn't all be to do that. And so the certifications are incredible. And building, frankly, a workforce that represents our families that we serve. So making sure we have Black, Indigenous, people of color, also being trained to support those populations because of all the things that Dr. Mahaffey talked about, the structural, not only stigma, but often racism or other biases that exist. So that's sort of like on the community representation side. The last two hats I'll touch on is, the evidence base really matters. So I'm fortunate, I'm an in-house advisor. So I'm actually a Massachusetts resident. I'm sorry, I hope that's okay. But I work as an advisor at Mass General Hospital Center for Women's Mental Health with Dr. Lee Cohen, Dr. Marlene Freeman. It's an honor serving alongside them to really bring the evidence base front and center. So as Dr. Cohen says, kind of bringing the science and stories together. And so in the evidence base, we're doing a lot of work in empowering patients. So whether that's going to womensmentalhealth.org to understand about medication use or different things around where does the evidence exist around honestly all reproductive mental health. So not just, as you put it, from menses to menopause. But also, frankly, we have podcasts, other projects we've been doing to really make sure we're disseminating that evidence base and meeting families and moms and birthing people where they are. And then on the provider side, similarly, how do we ensure we're working with our colleagues to make sure that they're equipped to take care of these patients with the latest and greatest with our blog and evidence base. So that's sort of the third hat. And then the final hat, which is newer, and I'm fangirly because I have to say, Paige, not to embarrass her, but she's a huge inspiration for this, is just, I'm in the early stages of starting my own business. So unfortunately in Massachusetts, we don't have access to perinatal intensive treatment programs. And I experienced that firsthand, not having access to those programs when I was hospitalized. And so I'm in the early stages of sort of building what it would take to start perinatal intensive treatment programs in Massachusetts, but also build models that really center the patient experience and that we can scale to states that lack access programs as well. So that's sort of all the hats, and hopefully that answered your question, Paige.
Well, Kriti, I want to say what an inspiration you are to this audience, to the world. And as somebody, yes, like you, who has used my own lived experience as a tool for change, centering the lived experience in the work that we do is so critical and so important. Involving people in these conversations around what would have helped you, what did you need, what do you wish you had that you didn't get? That can be one of the most informative ways that we can identify solutions that work. So thank you very much. Thank you to all of you for answering that question. I want to now pose to you another question. And I think, this has come up quite a bit in our conversation today. It really is the backdrop of what we're discussing, is this powerful role that stigma plays in really preventing people from accessing the care and support that they need and deserve. It's a real barrier. And I invite all of you to offer your perspectives on what are the consequences of not seeking help? What happens if stigma gets in the way or another barrier gets in the way of somebody connecting to care? And along that same line, what are some of the solutions that are either happening or that we can think about instituting to eradicate that barrier in others? So I want to open it up to everyone again. Whoever would like to jump in first.
I'll start.
Thank you, Dr.
Not to be too stark about it, but really the consequence is death. Mental health conditions are the leading cause of maternal mortality. The United States has the highest maternal mortality in the developed world. And so if we're not addressing those mental health conditions, we're opening up that risk to a huge number of mothers and to the consequences of that on their families. And then obviously, a little bit less starkly than death, there's morbidity for years. If people don't get treated, that affects not only the health of the woman, the health and the functioning of that family, and the health of that next generation. And I just think you can't be stark enough about this. I think that we all get a lot of messages these days about the maternal mortality crisis in the New York City subway now. There are ads about the maternal warning signs. That's amazing. And one of those warning signs is depression, right? So we really need to be aware of that. I also think that there's so much that we can do to combat this. I think there are so many things that people here on this call and elsewhere in New York State and elsewhere are doing. The existence of the access programs, the existence of collaborative care programs, the sort of increasing attention that we have paid to these disorders. But we just need to do more and bring it forward. The fact that people who are training to be psychiatrists and people who are training to be obstetricians, neither one of those groups of providers is required to learn anything about treating mental health in pregnancy or even diagnosing or evaluating it. That's shocking, right? We wouldn't accept that for anything else, and that has got to change. We've got to change those educational systems. And I think about it a lot whenever I have to renew my New York State medical license. You know how we all have to do those 3 hours of CME training on opioid prescribing. I can't remember the last time I prescribed an opioid, but I'm willing to do that because opioid use disorder is a big problem and we got into a real problem with it. So I gladly do my 3 hours of CME. I just looked up what's the prevalence of taking opioids and opioid use disorder among women compared to antidepressants and depression. So about 7% of US women take an opioid medication. About 3% will develop an opioid use disorder. For antidepressants, about a quarter of US women are taking an antidepressant. 20%, 15 to 20% will develop a peripartum mood or anxiety disorder. So why aren't we doing education when I renew my medical license? Why don't I have to take a couple CMEs in perinatal mental health? I just think that that's something like that is the solution.
Dr. Osborne, I'm so sorry. I really appreciate that response. And like when I have these conversations, and perhaps you all can relate to this, I just have this moment of like, women and birthing people are the fabric of our society. We create life. We create the population that lives on this planet. How is it that we are not investing more in the very people who create life to feel better and get the care that they need and deserve? I always have that moment in these conversations where I'm like, come on. So I just want to say that. So thank you for that. And Dr. D, I didn't mean to interrupt you. Please go ahead and respond.
No, I'll wait for my turn. That's okay. It was, I don't know if it's so much a response, it's more of a elaboration on what Dr. Osborne said. So yeah, so speaking of it, so the mortality is right. And so often we're focusing on the other forms of morbidity and mortality. So some of the cardiovascular, the hypertension, the hemorrhage, right? There's a lot of, even within much of the medical education, a focus there and less education on what's actually on the top, right? On the top of the causes for maternal mortality in the first year postpartum. So yeah, so I think we can't lose sight of that. I think that there are myriad effects though, in addition to that, right? So there's just far-reaching effects for the individual, for the child, and like I said, for the family. For the individuals, these symptoms can intensify over time. I think there's a misunderstanding or lack of education that these disorders don't go away on their own. Maybe so many of the people that I work with think that they present for treatment maybe 6 months postpartum, 9 months postpartum, like, oh, I felt this way. It started in pregnancy and it just got worse and it just wouldn't go away. There's this belief that, well, if it's related to this temporary condition of pregnancy and delivery, then it should go away when I deliver the baby. And that's, for most patients, not the case. And so symptoms can worsen, and that can lead to chronic depression or severe anxiety, suicidal thoughts or attempts, substance misuse. Many of these things can go together. and also psychosis, whether it's part of depression or bipolar illness. Psychosis can come into the picture as well, and we also know that these, again, linking to the physical health, that when mental health is not cared for properly, that's impacting, right? So we see patients present later to prenatal care. There might be less appointments that they're able to go to, or not being able to adhere to the recommendations for their medical illness. We know that there could be gestational complications. So we know that gestational diabetes and hypertension are worse in patients who are depressed during the peripartum period. And they may have higher surgical delivery rates as well, which can carry additional risks. For the infants and children, we now have, I don't want to get too research related, but we now have data that, for any pregnant patient that has an undertreated or untreated mental health disorder, doesn't matter what it is, we know that that illness is being communicated to the fetus through the placenta, through a bunch of biological mechanisms that we're still figuring out. And so we know that just the illness itself is putting that imprint on the child in utero, and then that child carries that imprint into life. And so, after delivery. And so we really have to think about, when somebody had said that it's about the child's health too. That's why I went into this, because I was going to go into child psychiatry. I'm like, I need to go in the womb. Like, I need to go earlier. So really we have to think about child's mental health in the womb and support them by supporting the pregnant patient, and that ability to have the best health right from the very beginning and into early childhood. So we want to empower and bring up the health of our pregnant individuals, because we're bringing up the health, we're raising the health of children of that next generation. And then for families, right? So perinatal mental health illness impacts, can strain partner and family relationships, increases stress, can reduce support. It just can also, downstream effects are lost productivity, higher healthcare costs, in some cases, loss of employment. We know that these maternal mental health conditions also strongly influence child and family well-being across generations. And so, as alluded to, I think in many of the conversations, the collaborative care programs, the peer support programs, which were touched upon, but Postpartum Resource Center of New York offered statewide peer support and support groups, educational materials that are critical across upstate, downstate, and east to west across our state. There are some specialized mental health centers that were growing up, but right now they're few and far between that are trying to offer tailored treatment. But then it also bring in beyond our state level to tie into some of the federal resources or national resources, like the TLC Mama Line, right? The 833 TLC MAMA. And this is the National Maternal Mental Health Hotline. And it offers free 24/7 support from trained counselors that can provide emotional support and referrals. The 988 Suicide and Crisis Lifeline. We have in our state doula and home visiting programs to provide culturally informed, emotional and practical support before and after birth. And these programs, there's a couple in the city and elsewhere, can be very valuable for historically marginalized communities as well. Peer-led groups, I think, as was mentioned, can be critically important to reduce isolation and to reduce stigma as well. And then, again, just another plug for Project Teach, providing really empowering the workforce and broadening our workforce to be able to do this work, for patients and families.
Thank you, Dr. Delagianides.
Can I jump? Oh, sorry.
Oh.
Go ahead.
Oh, okay. Well, just kind of along that same theme, I think that we need to also recognize cultural and ethnic, differences, right? And also perspectives. And so we've kind of glanced on it, but there are a tremendous amount of social determinants of health that impact one's ability and how their outcomes are, right? And so I think we can be inspirational and aspirational to have pre-gestational care or diagnosis, but often sometimes our patients do not have insurance outside of the framework of pregnancy. So they cannot get that diagnosis rendered, right? And I think when we think of it along the cultural line, I always talk about, an instance that happened when I had a medical student went to go see one of my postpartum patients to interview before we saw the patient together. And when he came back and spoke to me, he goes, well, she just keeps talking about she has postpartum, but I explained to her she had the baby, so she is postpartum. Because in some cultures, especially African American cultures, they refer to postpartum depression as postpartum. And so when we center this into cultural sensitivity and cultural humility, we have to also understand that when we look at a lens culturally, it may be called differently, right? And so for her to just even be able to tell us that, right? That is a big step in itself, right? Because this is something they may not talk about in their own home. Because guess what? Their mother may say, well, I dealt with it and I had 6 kids and I'm fine. You'll be fine, right? And so people don't realize this can last more, it's not postpartum or baby blues, right? It lasts more than 5 days. It can last years. And so when we kind of ground ourselves in these cultural perspectives, right? And also look at kind of what does it look like with the curriculum of medical schools, right? Or even residency training programs. We have a next generation, a pipeline of clinicians that's coming along, and they may not be able to diagnose it because they're not taught, or it's not discussed, or they don't have that training. They may do the 3-hour course and then just forget everything, right? And so we want to think about that intentional perspective to kind of ground ourselves in social determinants of health that impact outcomes, making sure that, especially if you're in New York, you know about Project Teach. I have used Project Teach in rural settings in upstate New York, and it is just a magnificent resource, especially when you're in maternal health care deserts and you really need to find a mental health specialist for your patient. So knowing that there are tools available, making sure that we change the curriculums to include this, to normalize the practice of screening, of identifying and approaching our patients respectfully, right? And understanding the framework of weaponization and what that means to people. One of the things we started doing in the Maternal Mortality Review Committee of New York City is actually looking at mental health conditions for patients or mortality for patients where the child was taken away. And what does that look like? Because again, these things are layered, and when they kind of stack on top of each other, then sometimes it all falls. And so when you said before, and what Dr. Osborne eloquently said, the biggest problem is death. Is maternal death. And that's the reality. And how does that then impact communities and families and then that child? So, there was a study that was done at Harvard, the impact on the infant in the womb, right? And what does that look like, right? And so we have to look at it across the whole lifespan. And we have to really be intentional, in terms of if we really want to address this, how do we normalize and destigmatize, maternal mental health, and if we really want to treat it, how do we develop a workforce that will really, really appropriately treat our patients? Because we have to understand this is a public health crisis, right? And it's time for us to have a call to action so we can address it.
Thank you, Dr. St. John.
If I could just add to, I think that there is this piece around the current sort of political discourse that I think is really unfortunately contributing quite significantly to stigma and increasing risk for women. And that is around this idea, especially like the Tylenol discussion and the discussion around whether it's safe to be taking any kind of medications during pregnancy. And we know, as it's been pointed out, that untreated severe mental health problems during pregnancy are a teratogen, right? They actually increase the risk of negative birth outcomes, of birth defects, and these kinds of consequences. And I think we're not keeping that in perspective, and these messages that we're giving women that it's not safe to take anything during their pregnancy. We're seeing more and more women coming in with their partners and being just absolutely terrified of taking medications that we know are safe during pregnancy. And then this lack of awareness that, okay, if that there are safe medications to take, and that if you don't want to take medications for mild to moderate depression and anxiety, that we should be treating first line with CBT. If you go to the UK, if you go to other countries, there are guidelines that say psychotherapy should be a first line treatment for mild to moderate depression. They can prescribe psychotherapy. Why can't we do that in this country? And why aren't we giving people these messages that there are safe options, and that prioritizing your health and your mental health is the best way to ensure that you survive and that your child has a parent, right? And that you're able to function in that caregiver role. So I think we need to also be advocating ourselves at a political level and making sure that we are communicating health science in an effective way, because I think that's one of the ways we can prevent maternal death and these really, really serious consequences for women and their families.
Go ahead, Kriti. Thank you.
First of all, so eloquent. I mean, I couldn't have said it better. So thank you all. I'll start with a consequence, but perhaps I'll go to the solutions. Because again, I like to think of solutions and systems. The only other consequence I would add, I think you're right, unfortunately, death is the most eloquent way to put it, is economic. So just for folks who don't know, untreated maternal mental illness, and whether that leads to death or other comorbidities, just between the parent infant dyad is $14 billion to the US healthcare system a year. It's roughly $32,000 per dyad. That doesn't even get into other things that all you heard folks talk about. 1 in 10 folks that identify as a dad has potentially a perinatal mental health disorder or postpartum depression. So like the consequences, if you just put the economic consequences on a healthcare system that's already burdened, and I mean, I'm saying this to so many providers on the call, you all are living it, is massive. So I just think that like oftentimes we leave numbers out of the equation. Oh, that was a nice pun. I didn't mean to do that. But it's really important. Like there's a real economic cost as well. So I just wanted to add that. In terms of solutions, and I actually saw Christy. Hi, Christy. Shout out to you. You put this in the chat, and it's something I often say too. So I mentioned I'm a marketing and customer experience person. So the one thing, and I say this like all the time, and I saw, again, Christy put in the chat as well, is let's just make a mental health plan early. So we've been talking so much about diagnosis and treatment, but if you think about early detection or prevention, one story I often tell folks is, so I fall into the camp of folks that had no known risk factors. My OB was phenomenal, but like I would not have been flagged even with the best laid plans, because unfortunately about 40% of folks who have postpartum psychosis don't have a prior history. It's really a combination of biology, circumstances, et cetera. Why do I bring that up? Because when I did my 20-week anatomy scan, I was told about all the things: gestational diabetes, we had the birth plan, postpartum hemorrhage, what happens? Okay, what happens? I was high risk for preeclampsia, I had PCOS. I mean, there were like thousands of conversations on what could go wrong. So I'm sorry, I don't buy the narrative that people are scared and afraid. We're scaring pregnant ladies left, right, and center with everything, and we're empowering them. And I think the issue that I have is that, you know, in my hospital discharge packet, I had 30 pages of collateral, and one of them did have perinatal mental health disorders and postpartum support international, including postpartum psychosis. My husband and I found that a year ago. Okay. And so I know all of you in health systems are like, let's go create like collaterals and magnets. Like, we don't have time to look at it when we're in crisis. So how powerful would it be to actually at the 20-week scan, if an OB or a PCP or a provider, whoever it is, could say, hey, like, let's actually talk about what happens if one of these things happens. What if you are unsafe? Like in my case, I was unfit to parent. So I was lucky that I had a partner that took care of my daughter, and DCF never came into the equation. But let's talk about it. Who's going to take care of baby? What is going to be your support system? What's going to be your planning? What happens if you can't breastfeed, if that's your plan, or you can't follow whatever your feeding plan is. So to me, like mental health plan early, if you just say it to everyone, then a lot of the stigma goes away because everyone has the same information. On that note, the family unit, we put too much onus on moms and birthing people. Forget even the shame and stigma. In some cases, they like, because of potentially intrusive thoughts or thought disorders or their clinical symptoms, they might not even be a physician. So I often say, I'm sure someone told me about Postpartum Support International. Was I of sound mind to know about it or even follow or even remember anything my therapist told me when I was in acute crisis? No. So I think that's the other thing is how do we bring in, whether it's a partner or a pastor or whatever it looks like, how do we make sure we're bringing in and all the psychoeducation, bringing in the family unit as well, and not just putting the full onus on mom or birthing person. You touched on social drivers of health. I'm really passionate about that. It's over 50% of people don't even go to their postpartum visit, 6 weeks. Oftentimes Black and brown people. So like we can have the best laid plans with screening and stuff, but how do we make sure that she gets to the appointment? So I think Dr. St. John did a beautiful job talking about social drivers of health and how we make sure we keep that front and center. The last few thing, I love what you said about the politics and the storytelling, Dr. Mahaffey. So like, how do we empower patients directly with the evidence base? How do we find different ways? It's something we talk about a lot at Mass General. I've been kind of talking to the providers. There's a certain kind of mom that's going to read the PubMed and all that. I was not that mom. So like, how do we use, marketing platforms like podcasts, webinars like this? How do we really directly empower patients or partners with the evidence base? And then the last one, which is an economic one, which is, it's, you said something earlier, Paige, which is like, where sort of the moms and birthing people like carry society and, all that stuff. You said it much more eloquently than I can. For all the providers or health system folks or people that are like pitching payers or your, philanthropists or venture capitalists or whatever, from the business side, what I would say is we need to make sure we measure what matters. So it's incredible that we can measure clinical outcomes of what happens on a screener, like an EPDS or a PHQ-9, but like, how do we make sure we're also measuring? Because there's no one who's in this space that can question this as a problem, but it's really important that we have shared language, not just with patients and families, but with investors, payers, community health systems. So I hate to say it, but like actually be able to speak the language of this is the economic problem and the consequences, but also measure what matters and translate that. Because no one is sitting here saying we don't care about moms or babies. They may just not have the shared language or understanding of the magnitude of the problem or the consequences of the problem. So that would be kind of I'll get off my soapbox, but those are sort of the solutions I had in mind in terms of how do we collectively get ahead of the systems problems that we have today.
Can I jump in again, Paige? Okay. Because I really wanted to pick up on what Kriti said about the economic issues. And I think one of the huge issues is that despite politicians saying we have parity, we do not have parity for mental health reimbursement, right? So insurance companies reimburse at much, much lower rates for mental health treatment than for other types of medical treatment. And part of that is just the way the system is built. Like we don't have any procedures that we can do. But the result is we have even fewer people who can take care of people because we don't have very many mental health providers who will even take insurance. I mean, it's better in Massachusetts, but in New York State, it's grim. And I think one of the things that I reflect on with irony is one of the reasons I pitch collaborative care so much is that it is built through the obstetrician and it pays better, right? So you're able to build something that is a sustainable system. And that's sad that that's what we have to think about, but it's vital that we think about it. And until we bring payers into the conversation, we are not going to make any headway on that. And we are not going to increase those access problems. So I think that that's a really crucial and important problem.
Dr. Osborne, I'm so glad that you raised that, and certainly has been my experience in many iterations of providing perinatal mental health treatment and care. It's an obstacle to accessibility, right? Affordability is also one of the biggest barriers to care. And because we live in a place like New York City, many providers are also trying to pay the bills and keep a roof over their head and feed their families. And it can be very difficult to survive on the reimbursement rates that payers provide. It's not a livable wage. And that requires a lot of people, even who have expertise in this area, to still remain out of network so that they can continue to survive and do what they need to do financially. And that is a huge barrier to accessibility. And I'm really glad that you raised that. And I know that there are organizations like the Policy Center on Maternal Mental Health that are really trying to tackle some of these bigger macro issues and inviting payers to the table so that we can start to tackle also this barrier of affordability. So thank you for raising that. And I also really appreciate, Dr. Mahaffey, you bringing something into the conversation that I just want to explore a little bit more with everybody. And I want to center it around why we're here today and really highlighting stigma. And as you alluded, there can be a lot of stigma around accessing treatment. There can be a lot of stigma around taking medication. And I'm wondering, for those of you who are really having these conversations on a daily basis with women and birthing people who have those fears, how are you positioning that conversation when you are trying to provide psychoeducation to a patient or a client in front of you who's feeling fearful, who might not want to do it because they've read the headlines or something of that nature? How do you have that conversation? I
Okay,
see Dr. Osborne, go ahead.
it's a very hard conversation to have. People are coming in having been inundated with messages that this isn't safe, that this is your fault, that you to be a good mother, you need to be pure and incredibly responsive to your baby, that mental health is not something that requires treatment. And so I think it's very hard to have that conversation because we need to balance the urgent need for treatment with the need to not make the patient feel guilty that she has this disorder. And so the way I tend to talk about it is I frame it as what I call a risk-risk conversation, not a risk-benefit conversation. There is no risk-free decision. If you have a perinatal mental health disorder, that is an illness in pregnancy. And I try to normalize it by using my gestational diabetes example or something else that this is a condition that requires treatment. And unfortunately, anything we do in pregnancy is some kind of risk. If you walk down the street, you are breathing in air pollution. And I can show you a whole bunch of articles on PubMed about how air pollution it has harmed the fetus, right? So we can't do anything in pregnancy without some kind of risk. But the way I phrase it is my job is to partner with the patient to try to make the decision that is the least amount of risk. And I know what the risks are to untreated mental illness. They're extensive, and we have lots of evidence for that. And I know what the risks are for our treatment, which fortunately are very low. And so I'm trying to balance that risk in that patient. Does that always mean that the patient gets a medication? No. Sometimes the lower risk decision is no medication. Sometimes the lower risk decision is, gee, you came to me and you were taking low doses of 5 medications. We might be able to lower your risk by reducing the number of medications and increasing those doses. So every patient, it's a different decision. But I think it's a really hard conversation because sometimes you say, well, the risks of the untreated illness are greater than the risks of the illness. Then the patient says, well, either way, it's terrible, and either way, it's my fault, right? And so you really have to normalize it, say, this is a medical illness, this is my medical recommendation. And I have a lot of patients who, even after I say that, are very reluctant to take medications. And what I always say is, this is your body, this is your choice. My medical recommendation, based on the evidence, is a strong recommendation that you do X. I can't make that decision for you. I'm going to work with you and I'm going to help you no matter what you decide to do. But this is what the medical evidence is telling me is the lowest risk decision for you. And sometimes it works and sometimes it doesn't.
Thank you, Dr. Osborne. If anybody else would like to jump in.
Yeah, I was going to say I completely agree with that. I think giving back power and control is incredibly important of your own body, of your own decision making, and then educating people on what to look for in resources that they're reading online. I think there's a lot of really confusing material that's coming out in the news. We do not do a good job in this country of educating people on how to be consumers of information. And so that's a place where I will talk with people about. I'll ask them, what have you been reading? What have you been learning? Tell me about it. Tell me about what you understand. And then I'll look with them and I'll say, okay, let's look at some resources. Here's some of the things that I'm looking at. And I'm not pointing them to a PubMed article. I'm pointing them to some of the better journalism that's out there. There is good science reporting. I'm pointing them. I actually went through and made a list of like links for our especially for our psychiatrists that they could be sharing that had good like FAQs that were more balanced resources and information. So teaching, doing a little bit of education around like, what do you want to look for? What are some flags that this might be biased versus what are some flags that this might be accurate? And encouraging people, because that's kind of like, you heard you can give a man a fish or you can teach a man to fish. We want to teach a woman to fish, right? We want to teach people how to consume information on health if we can.
I think I'll just jump in. I think I have often encountered patients who do not want to take anything. I don't want to take the crazy pill. I'm not crazy. And so they may label it with these negative kind of, you know, so society norms that it's called, right? And so what I do in those instances, as what my colleagues here have said, is that really kind of rooted in the science and evidence-based practice and up-to-date practice and give them that. But also what I do is I think repetition helps. So these are patients I'm going to see very short. There's going to be sometimes I see them twice a week. Just a little check-in. It may be a blood pressure check, but it's really a check-in so I can see how you're doing. Right? And I've had patients who I've seen weekly, and probably by the second week, they're like, Doc, I just can't do it on my own. I tried. And sometimes it's just the repetition, letting them know you're there, giving them the information, not once, twice, sometimes more than 3, 4 times, but also knowing that you are a resource, right? And kind of hitting them kind of with also the mental health providers, our social workers, our caseworkers, us working collectively, and then even kind of touching in with the pediatrician, right? Because they will take the baby to those appointments. So how do we work together and do maybe an additional screen while the baby's there, right? And so, and then also making sure, how are they doing on the lactation front, right? What does that look like? Because also they may incorporate their inability to breastfeed as a failure, which then contributes more to their, mood or anxiety disorder or, the depression. So, I think there are strategic points that we can make in terms of really how we approach and address and connect with our patients. But sometimes it has to be frequent and often and just continuous. And that's kind of what the techniques I utilize, because sometimes it's not a one-ons. I don't want to see you 1 week after you deliver and then 6 weeks. No, because you're drowning, So I'm gonna see you, we may have to do a blood pressure check twice a week. It may be normal, but at least I can check in and I can see you, and I can touch base with you and I can see how you're doing.
Paige, can I offer 2 thoughts from the lived experience lens, actually, which I know is not the clinical, just on this really
Please
quick?
do. Yes, Grady.
This comes up a lot in peer support groups. So as I mentioned, I facilitate peer support groups for psychosis survivors. As you can imagine, quite medically managed, given all the things that were shared earlier. 2 thoughts, and one which you all might not like for providers, and one which hopefully you will. Sometimes the message can't come from you. So I think, given all the things that Dr. Mahaffey said and the current environment we're in, and we often talk about like fear, uncertainty, and doubt in the marketing world and like what that means. Sometimes it's got to come from someone else. And so I can't tell you the number of groups, we always say like we're not offering medical advice, whatever, but like just being able to have a space to talk about it and actually talk about not only like why do you take it, but how do you feel on it? Like I feel like what are the sort of side effects? Like for example, in my case, massive amounts of weight gain that I still am dealing with, that I like, and my husband's often like, that's the worst case scenario, you're in good shape. But these are real things, like real consequences. And so I think like finding ways, whether you have like, I know certain systems have like family advisory councils or postpartum support international, or it sounds like Project Teach, maybe other places that have resources, like who else can be the messenger or how else? And so I love what you said, Dr. Mahaffey, of having like the resources. Is it a podcast that you really trust in the evidence base? Like, how do they, sometimes it can't be you, or the fact that it comes from you, especially, I love my reproductive psychiatrist friends, but especially if you're the reproductive psychiatrist, maybe that's the challenge. So that's like one thought from lived experience. And then the only other thing is like, what does this free up? Like medication can be such a thing, but like, is it something that's going to help them sleep? To your point of feeding, I had a lot of grief around not having to breast or not being able to breastfeed. But if it was the choice between like kind of laying out the opportunity cost. So like you're able to do this so that you can sleep, so that you can spend that quality time with your daughter in the nursery, or you can do those things. So we talked about how you're more than the diagnosis. I think sometimes we get overly clinical. So I guess think about who the messenger is and who else can kind of deliver that message, whether that's a lived experience person, whether that's a podcast. Again, not all podcasts. There's some misinformation out there. So we talked about, but then also how do you reframe it and talk about how this frees up other things in their life, right? And frees up and frankly, and it sounds weird, but like take out the medical aspects sometimes of the medications is something I think that comes up in support groups a lot. So sorry, just from that lens, I'd offer that.
Very valuable perspective. Thank you for that. And before we take a look at some of the Q&As that have been coming in from our audience members, I just want to ask one more question that I know I didn't give a lot of people preparation for, but I feel like I just want to address it before we move on to the next part of today. But I heard many of you bring up this concept of trauma-informed care. And I want to ask you, we're going to learn, I'm sure, when we review the poll results that we asked in the beginning of where do you come from and what is your professional background, that we have people in all kinds of settings and all kinds of different roles that interact with new and expecting mothers and birthing people. And in your own practice and experience, what are some simple strategies, tools, ways that people can integrate trauma-informed care in their work with perinatal people?
I like to also kind of focus and concentrate on what was the birth experience like. Because there are also birth traumas that occur while in labor and delivery. Although we talk about that being the best day of their lives, sometimes it's the worst experience that ever happened. And this can be contributory to how are they feeling and how are they recovering, and then also just how they are in the postpartum period. So when we think of that trauma-informed lens, it's the totality of everything. Right. So it could be, we talk about in pediatric, the ACEs, right? But we don't talk about kind of birth trauma and birth toxicity and what happened in the labor room. How were you treated by the nurses or the security or the physicians or the midwives or the medical students or the residents, right? And so how that, can also create a PTSD, a post-traumatic stress, disorder as well. So I think for me, I try to look at the totality of the experience as a lens and as a marker. And I think that we have to also understand that there are things that are triggering, right? And, or activating rather. And so we want to be mindful of that. And there's life events, and then sometimes, even though it may be a couple, it may be only one person doing the night shift and having the sleep deprivation and then struggling with breastfeeding and has the cracked nipples. So we need to talk about everything. And so I think I try to look at the whole span of what they're experiencing.
Thank you. Thank you, Dr. St. John. Anyone else?
I think that one of the things we underestimate is the adjustment to the role of being a parent or being a mother. And one of the things that I, as a psychologist, hear a lot from my patients is I don't know, I'm not sure that I have a roadmap for being a parent. And that being a huge, or what it is to be a mother, because I was abused as a childhood. So in my childhood, excuse me, as a child. So really going back and assessing, like understanding what the person's relationship was like with their parents, understanding that trauma is kind of on a continuum all the way from just kind of invalidation to, really, really serious sexual and physical trauma that you may not have a model for what it is to be a parent. And so we need to be talking about that. We need to understand what people's relationships were like growing up and those ACEs, those adverse childhood experiences, because that is a huge risk factor for the person's mental health and their ability to really make that huge transformation, that huge jump in your identity into what that means to be a mother or be a parent.
I think one other really important thing that I've learned a way of articulating this as the lone psychiatrist in a department of 100 obstetricians is to really make sure the clinicians understand that trauma is in the eye of the beholder, right? It is a person's perception of trauma that makes it traumatic rather than the actual circumstance. And I think about it a lot with a study I did, one of my research studies many years ago, where I did an event in the laboratory that was meant to induce stress. And it turned out I didn't pick a very good event. It wasn't very stressful. And so I didn't really get at what I wanted to get at with the question because it wasn't stressful enough. And when I looked at objective measures of things with the physiological things I was measuring, I didn't really see much of an effect. But when I looked at people's perception of stress, I saw an immediate and substantial effect with the physiology I was measuring, which had to do with people's heart rate. And that really brought it home for me that it really is what the person perceives. And I think it's really critical that we make people who work in obstetrics understand that, because to an obstetrician, that wasn't a traumatic delivery. That delivery went fine, right? But it may have been traumatic to the person. And I think that can help to encapsulate all of trauma-informed care, is to understand that you can't understand what this person went through at any point in her life. You weren't there, but it had an impact on her, and she's bringing that to the table here, and we need to be open to that, and we need to understand that that affects the experience she's having right now. And I just think that's so important.
Thank you for that, Dr. Osborne. Anyone else before we move on to the rest of our conversation for today? All right. Well, I want to thank you all for providing such a valuable perspective on perinatal mental health and stigma today. And before we take questions from the audience, as promised, I wanted to share our poll results. So, David, thank you for pulling this up. As we can see, we have a lot of social workers in the house. Hey, we also have nurse midwives, we have some prescribers, we have some psychologists. So thank you all for giving us a sense of who is here with us today. Appreciate that. And we have one last question for you to answer before we take Q&A. So if David, you want to bring up our second poll question for people to take a look at while we dive into the questions. And this really has to do with your likelihood of applying what you have learned here today. So if you can take a quick second, I'll give you the responses to those as soon as we get to the end of today's conversation. And I want to thank everybody in our audience. There's been a lot of conversation, a lot of wonderful insights, experiences, and questions that have come to us. There's so many, and I don't think we're going to be able to get to all of them. But I have quite a few here that I want to try to get through. And I think, Dr. Deligiannidis, I'm going to pose this question to you, and then I'm going to ask other people, please, to chime in if they'd like to. How do you differentiate between what's considered as being hormonal versus maternal mental health symptoms?
All right. So for someone who does research in hormones, I think hormones are really important, but they're not the whole story. So for my research, I have to be really focused and study the impact of hormones on mood and the brain and behavior. But then the job is to understand how it integrates to everything else. So really, you have to understand all of the pieces, right? The experience of the individual, their potential history of prior mental health disorders, their current psychosocial situation, any of the risk factors, the social determinants of health, all of these things sort of come together in a situation where these symptoms manifest from really what we believe is, areas of the brain that are struggling to communicate in the way that they optimally would. They, in fact, that starts to impact their, the ways they have feelings, they have behaviors, and the way they experience their world. So I think it's not one, it's everything. And the way I think about, the way we categorize or think about perimental mental health disorders, because there was one question was, can they even happen early in pregnancy? Yes, they can. And is that a hormonal response? We don't really know. We're still trying to understand that hormonal piece to this, and I don't believe that for everyone, the hormones are playing a driving factor, but I do believe for many individuals, it's a piece of the puzzle. And for some, I think it's a huge piece, like maybe the major piece that's driving the symptoms when either the hormones are high in pregnancy or when they come down very quickly right after delivery. And so even during attempts to conceive or in situations for infertility, we see individuals develop mood or anxiety symptoms during that time. And sometimes the treatments that they are receiving in infertility are obviously affecting the hormones, and that can cause dysregulation in the symptoms. But we have to also take a broader lens of everything else that's happening in that individual's life to have a more holistic understanding of why now? Why is it now that they're developing symptoms of anxiety or bipolar disorder or depression or stress, another stress disorder? So I'd like to think holistically. I do believe that for a subset, the hormones play a really important role, and for some, a driving role in the expression of perinatal mental health disorders during this time. And that's why we also see at other times of hormonal flux during either the menstrual cycle or perimenopause, we can also see a blip, an increase in the rates of mental health disorders in individuals during those timeframes too. So important, but not everything. So yeah, so it's a both and, I guess, answer.
Thank you for that. I am going to put out another question to everybody, of one that I'm of particular interest in. If anybody can speak to the prevalence and the stigma surrounding perinatal mental health concerns in non-birthing parents.
So we see numbers that vary in non-birthing parents. Sometimes a number you'll see cited as 1 in 10 for depression in non-birthing parents. That number is higher if we start to include anxiety disorders. And I'm super glad that you brought that up too, because our brains are plastic, right? Meaning they change over time, and they change in response to our environment and our learning experiences. And there's this idea of the parental brain, right? That this is a period where we're really primed, whether or not we have those hormones on board from being the person giving birth, for our brain to sort of change and develop new connections and new responses. And that can be for the better, right? To have this kind of caregiving response, but it can also be for the worse. And our previous learning and social experiences are extremely important. So for OCD, again, which is something I study, we know that we see about twice the incidence, meaning the onset of OCD in the peripartum. And that is true for both, mostly historically, it's been looking at mothers and fathers, but for birthing and non-birthing parents. And there seems to be this interaction between our existing sort of cognitive risk factors and beliefs. So if you believe that you're really responsible for preventing anything bad from happening that you think of, if you believe that your thoughts are really important and meaningful, you may be more likely to go on and develop OCD. So it really, like Dr. Delagiantis was saying, is really this interaction between our sort of biology, our neuroplasticity, our hormones, and then with those social learning experiences that we have that increase risk. And that means it's not just the birthing parent that's at risk. We really need to be paying more attention to non-birthing parents as well. And I think that's where pediatricians are really important partners. I think non-birthing parents and fathers are increasingly becoming more involved, thankfully, hooray, in caring for children and taking time and being more active in that sort of, fourth trimester, as we might call it. And so we need to be figuring out how to screen them and figuring out how to connect them with care and figuring out how to give them permission to also seek care for themselves, because they are also sometimes, in some circumstances, even more affected by this stigma. I mean, think about being a father and saying, I have postpartum depression. Like, that's a hard thing to talk about, right? And we need to be doing a better job.
I can briefly touch on resources, and I've lived it with my partner. I think he experienced postpartum psychosis. He's the one who interacted with the health system. He was the one who was the medical proxy for my daughter. And honestly, I sometimes say the system failed him more than it failed me. So I'm deeply passionate about this question. I love everything Dr. Mahaffey just said. One quick touch on resources and one other thought on resources. So for Postpartum Support International, it really is resources to support new families. So we actually have opportunities to, we have like weekly chat with dad. We have groups for non-birthing people, non-birthing parents, partners, even loved ones touched. I mean, my mom, I often say, like, I wish my mom had more resources as my night nurse, as the one who had to see her daughter go through what she went through. And so I just think, I think someone said it earlier, this is intergenerational. And so know that PSI, or Postpartum Support International, has specific spaces, including for postpartum psychosis. We have a group for loved ones touched by postpartum psychosis, because sometimes if you're not the one going through it, there's also a lot of shame of not wanting to burden people with what you're going through. And then the only other lens I would offer is, like, let's not stop at like heteronormative, heterosexual traditional family norms. And so I think there's so much, whether you're a single birthing person, surrogacy, adoption, infertility, post-loss, not to get more complicated, not from a clinical point of view, just from a lived experience point of view. I think I love that question, because I think we should also make sure we're keeping a close eye of the added layer of stigma and challenge when you don't even fit the traditional mold of family units to begin with. And how do we make sure we create spaces and resources for those folks as well? Or frankly, make sure we're triaging that differently, because it is very different for me in a heterosexual loving relationship, with a partner versus someone else who might have a lot less privilege or a very different family circumstance, layered on, or maybe not even a family unit to begin with. So I just wanted to kind of offer that thought as well.
Thank you for that, Kriti. Anyone else? I would just add, what we know to be one of the greatest risk factors of fathers and partners developing a PMAD or a perinatal mental health condition is if their loved one is experiencing a perinatal mental health condition. And so the two are connected. And, we can't have one conversation without the other. So appreciate that. Another question that I think is important has to do with screening. And I'm wondering, for those of you who do utilize screening instruments, what are the evidence-based screening instruments that we can use? And I always like to throw in this extra caveat, and you probably would go here, is that we do have some standardized instruments for certain conditions that are commonly used, but do they effectively screen for all conditions? And if not, what do we do about that? Big question.
I'm going to jump in on that.
Thank you.
In particular, because of what Dr. Mahaffey was saying earlier about OCD, which is under-recognized and underutilized. But I actually think the most important thing about screening is that we screen, rather than that we're screening for something in particular, because a screening tool is just a screening tool. It's just meant to identify somebody who requires further assessment. No screening tool is going to diagnose a patient. Only a clinician is going to do that. So I actually think the most important thing is that we screen with something. In my particular practice, I use the Edinburgh Postnatal Depression Scale, which is a very commonly used scale. And I use it for both depression and anxiety, because it has an anxiety subscale, because it's in my electronic health system and I can push it out to patients, and because I don't want to give them two things. Am I perfectly screening for anxiety? No. Am I screening for OCD? No. But I'm screening, I use a low cutoff, and I'm screening for general distress, and then somebody's going to have a conversation and get at what the patient's really going through. And then once the patient is in our system, then we do a much more detailed set of diagnostic measures. But I really think, even though I would advocate for the EPDS over some other things, I think the most important thing is just that we do it and we pick up that something's going on, and then we need a clinician's lens to discover what exactly is going on. That's my personal thought.
I agree. And I think that the advantage of the EPDS over some of the other common depression and anxiety measures that are used, like the Patient Health Questionnaire 9 and the GAD-7, which is screening for anxiety, they don't do a good job of accounting for things that are normative during pregnancy, like changes in weight, changes in sleep. And I will add the EPDS, even though it's called the postpartum scale, is validated for use during pregnancy. The one thing you also want to be careful of is keeping in mind kind of what cut points you're looking at, and that you're doing what I would call multi-method assessment. Some people will not answer yes to questions on paper, but will answer yes if you ask them verbally. Some people will not, answer yes to something verbally, but will endorse it on paper. So you need to, just because you gave a screener doesn't mean you shouldn't be verbally asking, how are things going at home? How are you feeling? Are you anxious? Are you stressed? Are you depressed? We need to be doing both. And then when I'm talking about cut points, there are different scores that are available that say, hey, this is a person that's screened positive. You might want to consider referral. In an OBGYN practice, you should be using a more maybe conservative cut point than you might be using in if you're in a mental health clinic and screening for these kinds of things. So you want to be thinking about those numbers for scales and what cut point you're going to use at an organizational level if you're going to screen. And then my big bugaboo is we have so many people who will screen positive. Our OBGYNs will screen them. They'll screen positive on the EPDS, and then they make a referral for care without talking to the patient. That is incredibly invalidating. Or they'll say, this person has a prior history of depression. I'm referring them for treatment. And then you talk to the person and they're like, I have no idea why they referred me. I'm not depressed. I'm fine, right? Please do not screen and not follow up and talk to the patient, and make sure that you actually understand what it is that they're looking for. Please, 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 please.
If I may add, so screen with something is what we also recommend. Yes, there are, health systems and community centers are using different screeners. Sometimes they want to have something that they can use that's been validated across the lifespan. And so they may choose a more general measure rather than one that's more specialized for the peripartum period. And sometimes there's flexibility in using two different scales depending on where a person is in their life and their experience. I do want to point out that I can't put it in the chat, but Project Teach has, we've created a repository of maternal clinical rating scales, and you can, what our team did was to look at the literature to see which ones have been validated in the peripartum period for either screening, diagnosis, or treatment outcomes. And so it's based by diagnosis, but we also have social needs, trauma, interpersonal violence. We have all the validated screeners for OCD, PTSD, substance use, eating disorders. They're there if you want them, and they're in as many translations as that we were able to find validated, and they're just free downloadable PDFs. Also, I'd recommend, because you're right, it's not a number and then, oh, we need to connect you with somebody, right? There's something that needs to happen in between. If that conversation is new to you, or you're not sure what to ask or what to do with that number, you feel like, okay, we've got the screening down, but we're unclear as to the next steps, give us a call at Project Teach. Our team can help you figure out how to interpret that scale, what questions to ask your patient, and to learn that skill set of a little bit of that interviewing to understand truly what is needed next for that individual. A person with even the same number, right? If it's a 15, it could be, either more severe anxiety or more depression, like depending on where they're scoring on the scale, right? And we also know that some of these screens, it's important to use sometimes screens that are more broad, because then we're getting, they're non-specific, and that's almost a good thing, right? Because then they're picking up lots of things. It might be ADHD, it might be, bipolar disorder, it could be anxiety disorder, it could be a substance use. There's different reasons why patients might be, reporting different symptomatology, because some of these symptoms are shared across disorders. So the screening is so important. Screening, picking something that you can use often. And then sometimes we recommend, depending on the screener, use the same screener once you start treatment to see if it's working and if it's helping. You can keep using that tool. The patients we work with, they really start to understand themselves even before they fill out the tool. They're like, I know my score's gone down. Like, I feel better. They've used the tool so many times that they develop a language for expressing how they're feeling. And that, I think, is just very empowering for patients to be able to put the words to their feelings and communicate that. Because sometimes they may not have the language, right? There's on the clinician side, it's on the patient side, and we're all trying to figure this out, but the screeners can be a first step.
Thank you for that. And I just want to piggyback on this concept that we're speaking of around the relevance and the importance of screening. And when we talk about barriers and obstacles to care, we know that for a lot of people, it can be really scary to be honest on a screen, right? If I tell the doctor or the provider, if I'm honest about how I'm actually feeling, will there be judgment? Will something terrible happen? Might my child be taken away because somebody sees me as an unfit mother? So how do we have these conversations that encourage being honest on these screens so that providers who will take this away from the conversation we're having today, how do we invite that safety with our patients and clients so that we can encourage them to really talk about how they're really feeling?
I mean, one of the things, we know that may work and has worked successfully is continuity of care. Having the same provider, having that bridge of support, utilizing, especially in marginalized communities, utilizing community health workers and doulas and the input from them. I mean, I've had cases where, I had a patient in labor and she had a doula and everything was fine. And then I go in and everyone is stoic with like kind of an angry face. And you're like, how you doing? Fine. And I've asked the doula to step outside and I'm like, what's going on? She's like, she doesn't like the blood pressure cuff. I was like, oh, that's easy. We can take care of that, but it's kind of understanding that we may get information from different aspects and you may not be the only one who should ask the question. And so, but we do know that continuity of care works and having the same provider and development of that relationship, especially during the pregnancy, can be helpful for them to be more forthcoming in that you're able to identify something earlier and be more helpful.
Okay, Dr. St. John. I'm going to put out another question. I know we're not going to be able to get to all of these, but I want to try to get through quite a few. And this is actually an interesting one. How well does perinatal mental health diagnoses respond to the same treatments as non-perinatal mental health diagnoses? Is perinatal uniquely different, therefore requiring a different approach, or would it be closer to treatment as usual for that specific diagnosis? I'm channeling you, Dr. Osborne. I see you shaking your head. Go ahead.
Well, I was going to say Christina should answer that question first because she is a great expert on one of our newest medications for postpartum depression that really has a specific resource. So over to you, Dr. Delagianidis.
Yeah, this is a tricky one, right? So let's see, where is it? So, all right. So looking at all perinatal mental health diagnoses, they do respond to the treatments that we have that are evidence-based outside of the peripartum period. So, and I think that's an important message because there is a lack of perinatal specific trained and certified clinicians across the state of New York and across the country, right? And globally. And so I don't want patients to, or clinicians to feel, well, we don't have those specialized resources, so they can't get the special, treatment that they need. Any mental health clinician can work with a perinatal individual and make progress and help with diagnosis and understanding the issues at hand and provide a treatment plan. And then again, hopefully with the Access program, who I who I spend the most time with right these days, is to bring in that expertise into areas that don't have it or where it might be helpful to have it. But there are, we think, and I said, I guess this links back to a question earlier about, we do think that the change in the hormonal environment across pregnancy and postpartum, they do have direct effects on that brain neuroplasticity, the brain changes of parenthood that are supposed to happen to get the brain and the individual basically in the best place to parent. And when some of those connections go awry, we see, symptoms develop in this peripartum period. So yes, there have been sort of the traditional medications and therapies, psychotherapies that we have used that are efficacious for perinatal mental health conditions. And there has been at least one novel medication that is different from what is used outside of the peripartum period. That is a postpartum medication that really addresses probably more of that hormonal component for postpartum depression. So there are some specialized treatments, and then the psychotherapies. What I think tremendous work has been done is an adaptation of those really solid evidence-based psychotherapies to have a perinatal specific focus and to look at the unique pieces of the perinatal period that can be adapted to those situations. So, but some of those might be challenging to access too. So, but we know that even with some of the research that's been done, it may not even need to be the specialized therapist or clinicians that can help individuals with perinatal mental health disorders. We know that everyone can help, right? So the home visiting professionals, the allied health professionals, the doulas, everyone can help. It doesn't just have to be some specialty treatment team. Everyone has a role, and I want to make that clear. It doesn't have to be some super subspecialty. There are cases when those treatments are really important and valuable because you need that expertise. I would say peripartum psychosis is one of them. There are very few people trained in that area, and bipolar disorder. And I would say peripartum OCD as well.
OCD.
Yep.
Right.
And well, now the list is growing, right? I can't just pick. I really can't just pick anymore. But yes, I want everyone to know that, if you're in an area and don't have specialized resources, that should not be a deterrent. Any resources are going to be helpful, for that individual. So.
Yeah. And I think the thing I would add to it is that there's a growing evidence base for that whole world approach. And we've known for years that you can teach non-specialist providers to deliver psychotherapy informed treatments. So we started out with the Thinking Healthy program, which is now recommended by the World Health Organization. It was started out as a treatment for postpartum depression in rural Pakistan. It's now used around the world. I'm actually teaching an adaptation of that to doulas here in New York City to prevent postpartum depression. And last week, we were at a conference where we heard the results of the Summit trial, which is sort of the largest perinatal psychotherapy trial done, where they compared specialist to non-specialist providers and telehealth to in-person providers doing a 4-session behavioral activation psychotherapy and found no differences among those.
Looks the same.
Absolutely the same and all effective, right? So we have a tremendous resource out there and ability to grow that workforce with people who are non-specialist providers. And again, then saving the resources of the more highly trained providers to do that postpartum psychosis or bipolar disorder.
Or more complex or treatment resistant, or yes, absolutely.
Exactly.
And I completely agree. I think, from a psychotherapy perspective, the front lines for, depression and anxiety here are CBT and interpersonal psychotherapy. I should say cognitive behavioral therapy and interpersonal psychotherapy. We know that there's that real need for social support in this time in people's lives as well. So IPT is maybe uniquely suited in some ways for this population. A big problem is we actually just don't have enough providers in general that are trained in evidence-based psychotherapy. Usually people in the community are going to be getting quote unquote talk therapy, which often is just sort of supportive in nature, which can be helpful, but we need to be also educating consumers about what to look for in terms of the training of their providers and to be really voting with their feet for people that have training in these kind of evidence-based treatments. For OCD, you really want to be looking for somebody that has experience in exposure and response prevention, which is a specialized form of cognitive behavioral therapy. They don't necessarily need to have that perinatal experience. It can be helpful just to kind of know what some of the thoughts are that are common in this period. But I would much rather somebody be going to somebody who is generally has expertise in exposure and response prevention than even a perinatal specialist that doesn't have experience with that treatment. So really knowing and looking for these, and also knowing that they're time limited treatments, right? I think a big barrier that a lot of people have to accessing evidence-based psychotherapies is that they think that this is going to be therapy for life. These are treatments like we just heard Dr. Osborne say, that can be delivered in as little as 4 sessions and really see a meaningful impact. So 4 to 16 sessions can be really transformative for people. And I think one benefit over drugs are incredibly important and are a useful resource, but one benefit of the psychotherapies is that these are lasting effects. Not everybody's able to stay on medications long term or wants to, and you can really see long-term change that even is going to extend outside of the peripartum period with getting access to these kinds of evidence-based psychotherapies.
Thank you all. And I'm going to end with this one last question. How can creating a proactive support plan, like the one I developed with an expecting parent who has a family history of postpartum depression, help expecting parents care for themselves, build support networks, and recognize when to seek additional help? I'm looking at you, Critty.
I'm like, I'm more floored at whoever asked that question. It's so like eloquently put. So I think a few things. We started off with stigma and, the beautiful presentation in the beginning of sort of the types of stigma. And I think normalization, I think just having a plan that things might not go to plan, and that part of that dimension is your mind, body, and spirit, and not just your blood pressure or your diabetes or all the other things that mentioned. I mean, it sounds very like maybe simplistic, but like I think there's the normalization aspect. And then I do think that, we live in a privatized healthcare system, which is so siloed and fragmented at the end of the day, and now politicized. And I think if we have a plan in place, there is like time and space to have the kinds of conversations I just had. Like, I am so astounded in a good way by like everything I heard. I'm like, okay, like next time my friend has a baby, I want you as an OB and you as a therapist and you as a psychiatrist, like in all seriousness, like intentionality. So I think the other thing is that it gives time and space to have those interdisciplinary, psychosocial versus not, med management versus not, forever versus 4 sessions, like actually to have those conversations before there's a baby in the picture or before there's feeding in the picture. And so I think too often we're like reacting in the moment. So I think like it sounds simplistic, but like the word plan, there's a level of normalization to say, you're planning your diaper bag, you're figuring out what breast pump you want. Let's go talk about the things, or let's talk about if sleep doesn't go. I often now get, unfortunately or fortunately, get a lot of calls from postpartum friends who are like, where do I find a therapist? I'm like triaging all the time. And I think it's one of those things where it's like, let's already talk about, or frankly, like, how do you feel about sleep? How do you feel about those things? So I think it starts the conversation, whether that's conversation within the family unit, with your doula, with your OB, maybe you already have a therapist. Like for me, I forgot to mention this, but I'd never seen a mental health provider. And I remember like having to find a therapist when I had left the psych ward that took my insurance. And the first one, I won't say what she said, but created severe anxiety because she was terrible because of what Dr. Mahaffey said. Like she took Blue Cross Blue Shield, but like she did not know what to say to someone who had left the psych ward as a new mom and was separate from the baby. So I just think, not to get really dark, but to start early and then have the time and intentionality to have that planning and make sure the right people are in your village or team, whether that's your personal life, your community, or your providers or set of providers. That would be kind of my main, not clinical, of course, but just sort of from a lived experience lens, what I would share in terms of that question.
Create your village. Create your village in advance. Don't wait till it's too late. Have a plan. And hopefully it won't happen, but if it does, you have a plan.
Yeah, and also one thing, regardless of diagnostic criteria, like the reality is things are underdiagnosed, but I feel like everyone should do this, whether or not they have a clinical intervention that's required. So that was the only thing I was going to say is I think it should be true for anyone who's going into this massive labor of love, both literally and figuratively.
The one thing I would add to that from a clinician's perspective is I've sometimes had patients who created a plan for how they thought their birth and postpartum ought to go, and then it didn't meet their expectations. And that can itself be inducing of anxiety or mental health disorders. So yes, create that village, create your expectations and hopes of how things are going to go, and recognize that things may happen that you don't expect. And so having that village and having that support to deal with the unexpected, I think is really, really important. And I really think that moms need the message that they aren't in this alone. They can't be in this alone. I can't tell you how many women I have who come to me in severe sleep deprivation, and I say, is there anybody who can help at night? And the universally the response is, oh, well, my partner's at work and I'm on maternity leave, so I don't want my partner to have to do anything. No, 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 no. We're not leaving it all on mom. We need to bring, and the partner is very willing, happy to do it, but the mom is reluctant to reach out to that village. So I think it's making sure that the message is there has to be a village who's in your village, and what are the things that you're going to ask help for. No, 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 you're not going to not ask help. You have to ask help. Who are you going to ask, and what are you going to ask for?
Mm. Such a valuable and rich conversation. I know that we had several more questions, and I'm just mindful of the time. So, for those of you that we were not able to get to your question, I apologize. And I think we're taking notes on who asked what question, and we'll try to get back to you with a response. What I'd love to do now is just bring up the final poll results and then close out this tremendous conversation that we've had today. Wonderful to see that the majority of people that are here today are likely and very likely to apply what they have learned. And that is accredited and because of each one of you that have shared your insight, your lived experience to really provide such a thorough education to our audience members. I want to thank everyone for being here today. I want to thank our panelists for this lively discussion. I want to thank our audience for their commitment to learning how to better serve pregnant and postpartum people experiencing perinatal mental health conditions. And I want to thank the New York State Office of Mental Health for recognizing the necessity of covering this important topic and making today possible. So thank you, everyone. I know we had just a few more slides that we wanted to show with our audience members before we close out for today. Some resources that we wanted to share with you all. There's a special issue of Behavioral Health News supporting maternal mental health and reducing stigma with the link provided. Please check it out. And also want to encourage everybody to visit the New York State Office of Mental Health Maternal Mental Health Resources, where many of the resources that we spoke about today will be listed. I think we have one more slide. Just wanted to give Roundtable 2 one last plug. It'll be happening next Thursday from 1 to 3:30. We have a tremendous lineup of speakers that will be talking about the support programs that exist in New York State and some additional solutions to overcome stigma. Thank you all for being here today. I hope you walked away learning quite a bit. And I hope everybody goes on to have a wonderful afternoon. Thank you so much.